Welcome, everybody. My name is David Barrosse. I'm the CEO of the Capstone Group. The Capstone Group is a policy analysis and regulatory due diligence firm based in Washington, D.C., London, and Sydney. And today I'm very honored to be hosting, along with the Chertoff Group, a webinar entitled Into the Looking Glass, What to Expect from the Coronavirus between now and the end of the year. And I'm joined by two distinguished guests, Chad Sweet and Dr. Jeff Runge. And I'm going to introduce them and then give you some instructions for asking questions. Chad Sweet is the co-founder and CEO of the Chertoff Group, a global advisory firm that applies security expertise and technology insights and policy intelligence to help clients build resilient organizations, gain competitive advantage, and accelerate growth. Chad served in the CIA and was the former chief of staff of the Department of Homeland Security. He is the co-chair of the Heritage Foundation's National Security Legal Working Group and is a senior fellow at the George Washington University's Homeland Security Policy Institute. At DHS, Chad worked along with our other featured guest, Dr. Jeff Runge, in helping our nation plan and respond to pandemics. Also, Chad and I have known each other for 40-some years. Dr. Jeff Runge was the first Chief Medical Officer and Assistant Secretary of Health Affairs at the Department of Homeland Security. As such, he was responsible for the development of the department's pandemic planning during the H5N1 avian flu outbreak in 2005. He also provided consultation to national medical organizations during the H1N1 flu outbreak in 2009. He joined the Chertoff Group in 2009, where he serves as a senior advisor. Welcome, Jeff.
Thank you.
I want to just remind folks that if they have questions, we will be making time to take questions throughout the webinar. You can write your questions down at the bottom of the screen on the video app. I also want to talk a little bit about the goals for the call. The first is we want to give you a clear picture of how government and policy is set up to respond to the crisis, how it's been prepared, what plans have been made in the past, and what you can expect to see in the future. Before I get into the details, Jeff, let me just ask you how you got involved in government and in the topic of pandemic planning.
Well, I'm an emergency physician by training. I practiced for 20 years in Charlotte, teaching residents and doing research in injury prevention and control and trauma care. Which led to my becoming the administrator of the National Highway Traffic Safety Administration during the first term of President George W. Bush. In 2005, I was asked to go over to the Department of Homeland Security to help Secretary Chertoff with establishing a chief medical officer role. Secretary Chertoff, one of the tasks of DHS at that time was to be responsible for and coordinate our nation's response to bioterrorism. And little did I know that a few months after I said yes, the president was going to read John Barry's book, The Great Influenza, actually at the behest of some prominent infectious disease people in the country, and came home right as Katrina hit on August the 26th of 2005. And asked the Secretary of HHS, I'd like to see the plan for this. I'm told that we're overdue for a pandemic. Let's find out what the nation is doing, which led to his biodefense advisor. Oh, and by the way, the president said, I'm going to give a speech on this in 2 months. And we went a national plan on my desk at that time.
But no pressure.
But no pressure. So for an injury control guy, this was interesting. And we set about with numerous tasks and do-outs for the departments to come up with a national plan. My responsibility was making sure that the Department of Homeland Security's plan and the way we coordinated with the federal agencies was sewn up. So a lot of that rhymes with what's going on right now. The interaction with states and locals, and unfortunately, the avian flu of 2005 and 6 did not become efficiently human-to-human transmitted And so it died out on its own, which is very fortunate. But the infrastructure that was created, the even down to the supplemental appropriation that was passed is very close to what was done in 2005 to increase capacity at the state and local level where this problem is going to be mitigated, as well as developing new technologies, hopefully vaccines, therapeutics, and so forth. So we've been here before, even though it was 15 years ago, but this is a bit different, and this in fact is the real thing because of its contagion.
And just picking up on that point, how would you compare coronavirus to the other flu viruses that you dealt with?
Well, everybody has heard, and it's quite true, that influenza, we have an epidemic every year, and it's predictable.
And we'll put a slide on just so that folks can see
Sure.
Some examples of that.
Okay,
Yeah.
Chad, thanks.
Yeah.
This one, so there's sort of two things to consider. One is what is the degree of contagiousness or contagion of the organism? The other is how sick does it make people? And on the far end of that spectrum is how many people does it kill? Every year, influenza infects thousands and thousands of people, and in fact, the estimates vary, but certainly people with underlying medical conditions also succumb to it, to regular seasonal influenza, and tens of thousands are probably the right number. This is a bit different in that it sprang from an animal reservoir at a certain point in China, in Wuhan, as we know, and was very, very quickly identified as an efficient human-to-human transmission virus. We also saw that people were dying of this virus, people who had prolonged and a large inoculum of viral exposure, even those who were not elderly or have underlying conditions. So rightfully, the world has responded appropriately with standing up plans, policies, drastic measures to try to curb this virus.
Great. Chad, let me turn to you now and ask you to give us the big picture of the role of the federal government and the different agencies and what roles they play in responding to the pandemic.
Well, it's a part of the reason why DHS was created was to help, as Jeff said, create plans so that all these different talents and capacities in the U.S. government can be coordinated for an event like this. And what I would tell you is, without going into every single player, the way to think about it, if we could use a military analogy, is in the military, if you're going into a battle, they determine who's the supported command, meaning who's the lead, and who is the supporting command, meaning who are the parties that are supporting. So in this case, if you think about in a battle, sometimes the Air Force is the lead, but the Navy's providing a platform to project power into a region. For a pandemic, the way to think about it is at the federal level, there's the federal level and there's the state and local level, as Jeff said. At the federal level, the challenge is borders out versus borders in. On the borders out, the federal government has clear authority. They are the supported command, they're the lead. So whether it's HHS collaborating with their counterparts abroad, whether it's the State Department issuing advisories, if it's at the border itself, that's DHS. Those are all federal authorities, usually coordinated by a lead designated by the president. And almost every incident, whether it was Katrina that we dealt with, or if you saw Obama dealing with the Gulf oil spill, they all ultimately need to designate a federal incident coordinator. And that's, in this case, the vice president, who the president has designated. I would argue that he probably should have designated him a little bit earlier, because there was a bit of confusion on this very point. And that, by the way, that was true in the Bush administration. It's been true in a lot of administrations. Obama took a while to appoint Admiral Fallon to lead the Gulf Coast incident, for example. So that's borders out. If you look at borders in, right now, the CDC under HHS are really at the federal level and the lead at the federal level, but the state and local governments are largely the supported command. They are literally the front line. And in our country, just because of the history of where we came from, fleeing oppression and authoritarianism from a British king, the authorities for quarantine, the authorities for a lot of the local health issues, that is left at the state and local level. So a governor with his health advisors, and usually there's a Homeland Security advisor, or a mayor, they will be the ones in coordination with the local health officials that have the dominant lead. And I'll use this to kind of liaise to Jeff to talk a little bit about why is that the case and how does it work in terms of the state and local governments being the support and command and front and center in an incident like this.
Right. So since we live in a federation, and we do not have central government authority to impose limitations on personal freedoms except in dire circumstances. And Chad's a lawyer, so he can talk about that later if we have time. But
I'm actually not a lawyer, although.
But you just play one on TV.
I just play one on TV, exactly.
Sorry about that.
I know your mom's disappointed about that.
So as Chad said, the tip of the spear really is at the local level. And when I say the local level, I don't just mean local government. If you think about a virus that is making hundreds of thousands, potentially millions of people sick, those people are going to get health care not from public health officers, but they're going to get health care from hospitals, physicians, mid-level providers, their normal patterns of care. The CDC has a centralizing benefit, has a tendency to centralize because they issue guidance which is scientifically based, and state health directors and local health directors will seek to fall in line with that guidance. However, when it comes to issues of hospitalization, in which our capacity is tested during regular flu season, much less this one, with respect to enforcement of isolation and quarantine, those are very, very local. They're police forces and sheriffs and the sorts of authorities that you might expect that would need to limit movement and personal freedom. It is in fact a criminal misdemeanor in most states to violate quarantine, which means that there has to be some consequences for violating the law. We are a long ways, I think, from being able to implement that sort of thing at the local level if it becomes necessary. But with the speed that this virus is spreading, and the fact that we don't have a vaccine and we don't have a therapeutic, and the only way this thing is going to be controlled is with public health countermeasures. We should be encouraging every single locality, every hospital, every physician's office, and developing a sense of common purpose and social responsibility among people, that they do the right thing so that we can get this thing under control.
So is it fair to say that if the public health response is definitionally on a state level, does that mean there's going to be variability? That some
Yes.
states are going to do this better than others?
Yeah, as I said, the CDC will provide hopefully very clear and unambiguous guidance to their state and local counterparts, so that the health information will be consistent, and the health response will be also somewhat normalized. If we get into a position where we have forced quarantines or the limitation of movement, those are the places where we really have not exercised properly, have not, and frankly, engaged with local authorities sufficiently to do that sort of thing. And that's going to fall upon local political officials to give those directions, and they have to win local elections. And I don't know how it's going to go.
Is it fair to say, I'm calling it audible, this question wasn't on the list, but I mean, is it fair to say that is polio the last time that we had any kind of experience with quarantine in this country?
I can't answer that question.
Oh, well, that's the danger of calling it audible.
Yeah.
Well, let me.
But I will say this, David, it's interesting. The quarantine that was enacted by this administration on the folks that were brought back from China, that's actually an example of the use of federal authority under the Commerce Clause, under the Secretary of Health and Human Services, and that's not been done, for decades.
That's correct.
And if you think about what just as Jeff touched on, I think right now we don't know yet. We haven't seen anything remotely like what China did or what, frankly, the Koreans did, and what we just saw yesterday, where Italy is now declared, quarantining the whole country. In Israel, if you violate a quarantine, you can go to jail for 7 years. In our country, one of the things that Jeff and I had to deal with, when you think about implementing this, the police force, doesn't have that. They're not vaccinated, so if they come in contact with somebody who is violating the quarantine and may be infected, they could get infected. Our society as a whole, we don't actually want to take an infected person and put them into a prison population where they can end up. You'd have to isolate every one of those individuals. So the model that the Chinese did, which was much more draconian with other authorities, top down, we're not a top down country when it comes to the quarantine authorities, unless it's an extreme emergency where the president would have to use extraordinary authorities. So I think the bottom line is what we've seen in other parts of the world, particularly in China and South Korea, that is not something that under our current structure we're likely to implement. And as a result, it may mean, doesn't matter, this is not a knock on this president or any president in our country because of that historical tradition. It's going to mean that there will be variability of how these quarantines are done. They're going to be mostly self-quarantining with authorities doing light touches. And at the end of the day, the police aren't trained to handle those folks. They don't want to put them in a jail. So at the end of the day, this is going to end up being somewhat slower in the way that it's contained. And I think that's one of the issues that we should talk about is
Right.
expectation management.
And to take off on that, we shouldn't ever get to the point where local police have to go arrest somebody for violating a quarantine. We need leadership at this point in time to get everybody on the same page. We need leadership from the top all the way down through local health officials, ministers of churches, thought leaders in communities that can make this ridiculously simple for people, and the development of a sense of social responsibility around this. To diminish the gravity of this situation is completely irresponsible. Don't want to overblow it by any means. We are hearing some good things about the transmissibility. It is probably going to turn out to be something like SARS 2003, which is significantly transmissible. But again, that was controlled through good, sound public health measures and isolation and quarantine.
On the topic of quarantine, and as I understood both of you, the federal government's role is limited in that, but I think one area in which the federal government, following what Chad said, would have a role is if people are coming inbound to the United States at the border.
Right.
And so I guess my question is, anecdotally, I've heard a number of people express reluctance to travel overseas. At first, it was to places more heavily hit, and now it's become anywhere overseas for fear that they will not be able to re-enter the United States. Mm-hmm. What's the current policy and on that, and what is the how would you speculate that might evolve?
I think on that one, and Jeff can talk about this too, but I think the good news there is that this administration is not trying to keep all Americans that may have been in an area out of the country permanently. And in fact, if you're a U.S. citizen, you come to our shores either through the airports or through a land port or a seaport, you'll be put through the normal customs process. We've got enhanced screening now set up to look at whether someone in fact may have the disease. But if you're coming from, for example, what this administration did was in China, if you were in Wuhan, in the area that was affected, when you came, you would have to be put into quarantine for 14 days, which is the period in which this would incubate and then manifest symptoms. And if you don't have any after 14 days, then they will release you at that point. If you weren't, for example, in Wuhan, you were another part of China, you come back, then they would actually, there are 11 airports that these flights are being funneled to. Enhanced screening is done there. If you're not exhibiting symptoms and you answer a series of questions, then they'll ask you to put yourself on self-quarantine, as Jeff said, and that's going to be done, at the honor of the individual to take care of themselves and not infect their community. But that's the bottom line, is that if you're a U.S. citizen and you're coming back from abroad, you should have no fear that you'll be permanently kept outside of the country.
And maybe this is just slightly unfair to ask you to speculate about this, but is it possible? Is it possible we could get to a point where the federal government decides that closing the borders to travelers of any nationality from certain hotspots is a prudent policy and people will be stranded?
Well, it doesn't work. So, I mean, whether or not they make policy around it, I can't predict that, but I can predict that it won't work. I think that's the cat's out of the bag. The disease has crossed the border. Moreover, and this goes back to policy discussions in the inner circle of offices at the White House in 2005 and 6. We are not going to keep Americans away from home. The policy, and I think we've seen hints of this with current utterances from the government. If you're sick overseas, and the advice right now from the State Department is seek commercial travel to get home. That's on their website. So I think there is an acknowledgement that trying to selectively prevent people from coming in from places is not going to work. However, as Chad said, the advice now is much more about taking care of yourself. So the State Department in the last couple of days has said, if you're my age, if you're over 60, don't get on a cruise ship because it's not good for you. And when you get off of that cruise ship in Ecuador, you might not want to spend 14 days, or if you have a fever, you might not want to spend any time in a hospital in Guayaquil. So there is an element of it's your responsibility to take care of yourself. The other thing that I read today, which also rings back to 2005 planning, is it would behoove everyone who can to store 2 weeks of food, water, pet food, and medicine in their homes in the event that they need to quarantine for some reason, they get exposed, or if they're asked to stay put for 14 days, that they don't become dependent upon somebody else for their literally survival. Hang on a second. The sad part of this is that about a third of the population in this country does not have the cash on hand to go out and purchase 2 weeks of groceries and pet food and medication. So we do have some responsibility as a government to find out who these people are early before a crisis occurs and to provide them with what they need.
I'm building on it. I think one thing that I would just add, David, is that the administration did move to restrict people from certain hotspots, particularly China and Iran, so that those were not U.S. citizens, obviously, and they don't have a right to come to our country if they're infected, nor should they. And so I think the administration did a good job in moving quickly on that. The thing that we couldn't do, to Jeff's point about medicines, for example, is we get a tremendous, vast majority of our pharmaceuticals come from China. So we can't stop all flights from China. We actually need that in order to deal with the crisis. So they are permitting flights from China that have predominantly cargo, and that's going to continue. Now, in terms of the issue around risk-based approach, one thing that's important is, I think, setting public expectations about what do these travel bans do, or travel restrictions is really what you should call them. They're not meant to, as Jeff said, keep this microbe, this virus, across 100% outside the border. One of the, I think, failures of communication that we all fall victim to is if we end up expecting perfection. And I think when we advise clients at the Chertoff Group on cyber, for example, one of the very first things we talk about with a board is to say, if the expectation is that you have this old school mentality that there's a permanent antivirus wall around your company with AV software, and that your expectation of success is 100% no breaches ever, that's going to be a failure by definition, because you are going to get breached. And instead, really, the model that we need to think about for the country is actually an analogy to the human immunosystem itself. Our bodies let in a certain amount of bacteria and viruses every year. We can't eat food if we don't allow that to happen. So, but the point is that we have a system that detects bad items and then creates antibodies to attack it. So that's really what I think the president and the administration are trying to do is slow this. They're not going to have success in keeping 100% out. And if we need to set with the public's expectations, as Jeff said, what does success look like? Success is not 0% infections. Success is going to be, can we slow it enough until we get a vaccine to bring this under control, or that it dies off?
Right. I mean, and to put some arithmetic around that, the goal here is to keep people who are infected from infecting more than one other person. Because if you can keep that
Multiplier effect down,
so-called the ratio of people who become infected from one person at 1 or less, it will go away. As long as I'm infecting 2 people, the epidemic is going to be propagated. So this really is about keeping people from infecting other people. And that's all we've got right now. We have no vaccine and we have no therapeutic. And we don't know if this coronavirus is going to diminish in the summertime as the flu normally does. There's really no evidence that this virus would do that.
That's interesting, and I want to pick that up in a few minutes, but I just want to go back to the question on flights, because I think that there's a lot of confusion around this, and I think you gave the answer, but I just want to clarify. So the vice president mentioned in his press conference last night twice that the administration had suspended travel from China, and I guess what I thought that meant was that passenger flights had been stopped, but that's not. The answer is more nuanced, isn't that right?
It is. It's more nuanced, and it is correct that there is a significant travel restriction that's been placed on, and the 2 hotspots have been officially declared are right now China and Iran. Even though there's an outbreak in Italy and South Korea, those are not yet officially hotspots, although CBP is looking on notice to be looking for folks from those 2 countries. It's important to note that CBP, the Customs and Border Protection, themselves are not medical experts. So what they're going to do is they're going to spot people and then direct them to HHS or other local authorities at the ports of entry for inspection. But the key point,
and when you say spot people, you mean if they look sick?
Correct. And if they answer,
if they look sick, they're going to be referred to secondary and to medical.
So this is the other thing I want to clarify, which I don't understand. I mean, one of the most, I think, widely known facts about this virus is that people can be asymptomatic for up to 2 weeks.
Right.
So what does screening mean in that context?
Yeah.
I get off a plane.
Very good question.
I'm not sick. I don't have a fever.
Right.
I'm not coughing.
You got global entry.
I come up to a CBP agent. If the agent says, "How are you feeling?" I say, "Fine," and I walk through. Is there another level of screening? Is there? Last year was in Singapore, and I think from the days of SARS, they had
temperature scanners,
and things like that, and
you had to fill out a history form, a travel history form as well.
Yeah. It seemed like you were taking on some legal liability if you didn't tell them that you weren't feeling well. What is the reality of what screening at the airport means?
Well, the thing you said, and let's get to the bottom of this, is it's only going to be as good as the answers to the questions that they give, and then secondly, if they're exhibiting symptoms. So I think to Jeff's point, is it possible that somebody honestly answers the questions and they don't know they have the virus and can get through, or they dishonestly answer and they're not exhibiting symptoms and they can get through? That's correct. So again, going back to that fundamental principle I said before about setting expectations, this isn't about 100% perfect solution. It's not going to stop, frankly, somebody that's not exhibiting and that misleads on the questionnaire. And we have implemented some limited technologies. We've done temperature reading screening when I was in office. Some of it is inaccurate. You can get people that have a temperature for a totally different reason. But nonetheless, some of that technology is needed, and it's being used. The reason why that they're funneling the flights from hotspots to just 11 specific airports is to help have that enhanced screening capability. But the fundamental thing that people on the audience should take away from this today is, again, containment strategies like travel restrictions done by the federal government are meant to slow this down. They're not going to stop at 100%, and we shouldn't set that expectation.
That makes sense.
Yeah.
And Chad, we discussed earlier your view about the potential spread of the virus in the United States and how that might be different from Asia. Tell me a little bit more about that.
Well, if you look at China and South Korea, for example, both have cultures where it's a much more of a community type. We're a very individualistic society. We're very proud of the freedoms that we have. So from a cultural norm point of view, it's a lot easier for South Korea or China to order people to stay at home, and they'll do it. In our country, it's going to be tough. And I think the other issue, as Jeff touched on, it'll still be an issue at the local level. Most of this will be self-quarantining. It's not, could we get in a scenario where there would be forced at a high level? It's possible, but I think it's much more likely to do what Jeff said, which is the low-level self-quarantining. And if we do that, at the end of the day, partly because of this country, before the quarantining began, we have more wealth per capita, so people have traveled more. So if you've been infected, you have a broader span of people that you've touched. In addition, I think what's interesting to note is right now, one of the kind of unfortunate realities is even if the CDC finds out that Jeff has been infected and he was on a flight, if the CDC goes to the airline and says, can you give me Jeff's phone number? Can I get his home address? I need to contact him to do tracing. The reality is the airlines, and you know this, and I know, unless you've done TSA pre-check where you've given extra information, anyone can buy a ticket on an airplane with just your credit card and your name. You don't have to provide your cell phone number. You don't have to provide your address. So we're in a situation right now where the airlines are doing the best they can. The cruise ships also have a bit more information because they typically will have passports and a little bit more. But the social tracing that you have to do to actually figure out who Jeff touched and to warn those people becomes even more difficult in our society than it is in a surveillance society like China, where they have massive amounts of facial recognition, closed circuit television. They have a social scoring system with digital technology, much more invasive to privacy than what we have. So for a whole host of reasons, I think what we need to do as a country, for those that are on this call, listening on the call or watching on the webinar, is to know that we shouldn't view the spread of this, if it's faster than China, there are good reasons why that is. It doesn't mean that our government is failing us, but it goes back to Jeff's point about it underscores that much more the role of the individual and really taking seriously their role in this, as well as the private sector's role, which we've been encouraged to see has been quite forward-leaning.
Right. I mean, you know, the CDC has this group of people called Epidemiological Intelligence Service. These EIS officers, they do this. They love this stuff. They love contact tracing, but it is hard work and it takes a long time. And it doesn't take long before the capacity of contact tracers is overwhelmed by the numbers of cases. Not only that, but I heard Dr. Fauci say something that, you know, I'm sure is obvious to him and everybody else, and that is that when you have a critical mass of cases, you will begin to get community infection, and contact tracing will no longer even be possible because you can't figure out where it came from. So if you happen to be shedding viruses, you haven't manifested an illness yet, or maybe you're just a young, healthy guy and aren't going to get sick from coronavirus. You know, I'm an old guy. You know, you're going to give it to me, but I would never think about you as having been the source of my illness. So you know, we have to think about this approach in phases, and we are quickly moving out of the contact tracing phase as our numbers of cases get larger. You know, when we were talking on the phone the other day, I just went on Kayak and looked at the number of flights to RDU, to my little airport from Beijing, and you know, there were, you know, half a dozen or 8 flights that could get me home from Beijing on the same day into RDU. So now, having said that, the State Department has issued a level 4 advisory, a do not travel for China. So it's not mandatory, but the advice of the State Department is do not travel to China because of the coronavirus. So again, I think if people, you know, heed the warnings and these warnings make sense, that's really a first step.
And we've seen, to Jeff's point, what is encouraging is the forward-leaning nature of both the private sector and state leaders. If you look right now, live in Maryland. Governor Hogan, we had 3 cases of coronavirus. He's immediately declared a state of emergency. And when we go back, David, to the question about the role of government, the states are the front line, and most of them have rainy day funds, or they have different types of scenario analysis for this. So by Governor Hogan doing that, he's enabling the state of Maryland to start mobilizing in advance the resources necessary. We're seeing that in Washington State. It's now basically infected about half of all of our states right now. My guess is if it keeps up at this rate, by this time next week, it'll be virtually every state in the nation. So watch for all these governors who have already been leaning in. They had the National Governors Association here in Washington just a couple weeks ago. Dr. Fauci signaled that this might be coming. So I think the states are leaning forward. And if you look at the private sector, we're seeing at the Chertoff Group, a lot of clients are not waiting for the government. They're proactively suspending non-essential travel. They're telling their employees to prepare for telework, take everything home every day. So I think that in this case, to Jeff's point, we're going to need not just a whole of government effort, but we're going to need a whole of society effort. And if you look at it, most of the time, the private sector can be more nimble than government in a lot of cases. And we're certainly seeing that play out now.
I'm going to ask you both I'm going to try to push you, I think, a little bit outside of your comfort zone and ask you to speculate about a more extreme scenario. So former FDA Commissioner Scott Gottlieb on Twitter the other day asked a question, which I thought was quite interesting, pointing to what he saw in China and Italy, with at first closing down the Lombardy region, in Korea closing down the area around Daegu, that a national government in 3 very different types of governments in those 3 cases had the power to isolate the impact of the virus and effectively to ask a region or a city to sacrifice their economy, so to speak, to save the lives and the economy of the rest of the country. And what we've been saying so far suggests that is not the way we are set up, that the federal government doesn't have that authority, and that these are up to the individual states. But is there any way a version of that could happen? Is there any way that either the White House could ask New York State or Washington State to do some things, or the CDC could specifically target those locales and say, we want you to do X, Y, and Z? Is that you told me ahead of time speculating like this might not be your first choice, but I think understanding kind of what the bookends are in that scenario would be interesting for people.
So I actually have thought about this since you posed the question. Since these authorities to limit movement, to increase inconvenience, to, as you said, sacrifice, these are largely state issues. Governors listen to their constituents, and their constituents come in all shapes and sizes. They're going to listen to the business leaders in their states. They are going to act in their own self-interest. I think I do believe that people who have risen to the level of governor probably understand that these sacrifices are not permanent, and if it's better for the social good to enact policies earlier than other states in order to limit the spread of this disease and make it less permanent, make it more temporary. I have a belief and a hope that they'll do that. If the guidance that is coming from the federal government is science-based, is devoid of political overtones, I think you can expect compliance with that.
And then if you look at the other element is, we talked about the federal government has in the inside, borders out, lots of authority, borders in, more limited, but they also have a carrot in addition to giving the guidance that Jeff said. So to Scott Gottlieb's question, are there other ways? One way is that you could provide economic incentives to states. So I know, David, from a Capstone perspective and what you guys are monitoring on the Hill, I think one encouraging note to the audience, at a time when there's been partisanship here in Washington, that's no secret, but both sides of the aisle got together along with this president and passed a very sizable initial emergency appropriations, and we've got a slide on that which I'll put up for our audience to see in terms of how that breaks out between HHS, Health and Human Services, along with State Department, and then the SBA, the Small Business Administration funding. Based on what Capstone's seeing, David, the president and vice president came out last night with the task force and started signaling some additional fiscal stimulus measures. What are you guys seeing, and what's the prospect of that getting through?
Yeah, well, I think that the first thing to understand is that the $8 billion isn't economic stimulus. That for anything to be economic stimulus, it has to be in 50 billion and above, and probably if you use past benchmarks like the Recovery Act in 2009 after the financial crisis, that was 800 billion. And so to make an impact on a country the size of ours in terms of GDP, you need a big plan, and a big plan is going to be political. And I think that's if that was true in the past, it is certainly true now. And just to remind you, the Recovery Act, just to focus on the House for a second, it passed with only Democrats and no Republicans voting for it. And afterwards, there was a lot of partisan bickering about whether it was useful, whether it was the right thing to do. Now we're in a scenario where we have a Republican White House who, as of last night, acknowledged the need for economic stimulus. And we'll see how Democrats respond. We'll see how grown up their response will be. Our belief is that there will be economic stimulus. There will be a large package. My sense is that the initial effort in that will be too small, and there will probably be a phase 2, if not a phase 3. What the White House said last night is that they would focus on a payroll tax cut, that those are usually temporary. Some type of assistance for workers, unemployment insurance or something where, to use the president's words, folks who were impacted through no fault of their own could be helped out. And I would point out that both of those have some bipartisan advantages. One, Obama passed a payroll tax holiday. And two, it's hard to imagine Democrats pushing back against an increase in unemployment insurance. It's already being discussed by the speaker. Where things get a little bit more controversial, I think, is what we know is also on the table, which is direct assistance to specific industries. The airline industry, the cruise ship industry. I think the president had a quote today that they're looking at assistance to the cruise ship industry, and the hotel industry. That is going to be altogether a different topic, because I think there are plenty of Republicans who will bristle at direct support to these industries. The aviation industry is one thing, but the cruise ship industry is most cruise ships are foreign flagged with foreign crews, and they're floating tax shelters. So that creates political problems. And then, of course, given the president owns hotels, there's certainly going to be issues around how hard he can lobby for a bailout of the hotel industry. But
even if the hotels have unionized labor forces.
Well, that is certainly something that cuts in the other direction.
Yeah.
So I think in the aviation industry and the hotel industry, generally speaking, you have large, powerful unions that are supplying the labor. Not true for cruises, which I think is going to be a challenge. So to sum it up, I think that there will be an economic stimulus, but my guess is that we'll see some political ugliness in the early days, there will be a bill passed, but that initial bill will just be too small, and then there'll be an immediate second debate about doing a 2.0.
Do you think one of the things that wasn't mentioned, there is this idea of targeted help, right? And the example you gave for Scott Gottlieb in, let's say, Seattle, the city of Seattle, that seems to be right in the spirit of using the carrot of the federal government to go in and try to get them support to do the right thing to hopefully can slow down the infection. What about if you look at the virus itself on the farmers' side of the equation? A big part of the Trump administration agenda on the trade war with China was short-term pain for long-term gain. Hang in there with me in the initial phase. As soon as we get through this, we'll come out on the other side and you'll sell even more to China. Now with the coronavirus having dealt a devastating blow to Chinese domestic demand, do you expect to see farm aid as a follow-up as part of this targeted aid? And is phase one trade deal effectively dead in your view?
I'm glad you brought up China, because I think there's, outside of the fact that it's the epicenter of the coronavirus, it has been dominating a lot of the work that we've been doing. On the trade side, I don't think that the phase one is dead, but certainly our contacts at the White House suggest that agriculture purchases have not begun, and that's both an area of concern, and certainly people can understand that the Chinese are not in any mood to sort of have that conversation right now. There are other policies related to China. You mentioned API, or the pharmaceutical ingredients, where we have a heavy dependence on China for those things.
Mm-hmm.
There was already bipartisan concern on a national security basis for trying to reduce our dependence on China of those things, and our analysts have published on this several times. The coronavirus compounds that. It's just another reason why we shouldn't be dependent on a foreign country for those critical ingredients. To answer your question, I think the likelihood that direct farm aid is relatively unlikely, because I think the goal of any economic stimulus is going to be to help the people who are hurt the most, and I don't think farmers are going to be in that category of people who are hurt the most. But then you're going to have economists arguing that you don't want to help people in a headline way. You want to use stimulus in a way that can help the economy, that can restart the economy and move the needle as quickly as possible. And that is a challenge at the best of times. So it's particularly a challenge when spending money is both about having excess and wanting to go outside. And this situation is unique in that it may keep people out of stores for reasons other than the fact that their pockets are empty. Let me pick up on something as we're winding down. That we had a question from actually a couple of clients come in about hospital infrastructure and availability of beds. And Jeff, I just wanted to bring you in here and ask you, when you were planning for pandemics in the Bush administration, how did y'all think about hospital infrastructure and the requirement for beds and emergencies, and how does that play out?
So, stating the obvious, but I will state the obvious, and that is that people get health care not from public health policy makers, but from largely private sector healthcare institutions and physicians, mid-level providers, and so forth. There's no economic model for creating excess capacity in the healthcare system to sit around and wait for something like this to happen. Even operating rooms, you don't keep it was a struggle to keep an operating room vacant for trauma patients that we knew were going to come in, but the hospital really needed to have those operating rooms, cooking all the time in order to make the economic model work. So there is no excess capacity. We are in the middle of a seasonal flu. We're winding down from seasonal flu, but we still are seeing long waits in emergency departments. And again, this is not just infectious disease, but we have, teeming, our EDs are teeming with mental health patients because of the failure of the mental health infrastructure to be maintained. It's a mess. I mean, I hate to summarize it that way, but there is no capacity to absorb a giant coronavirus outbreak. So it's a real concern, and we knew this when we were planning the H5N1 avian flu deal. And the HHS has a hospital preparedness program. The CDC had their own program at that time. It was largely money on a stump. There were really no outcome measures. That changed during the Bush administration. I think it was directionally good. I'm not sure how successful that's been. Are hospitals better prepared than they were 20 years ago? Maybe a little. But they tend to spend money on those things which have a return on investment. And there's just not much of a return on investment on paying for prevention. So I think this is a big deal. We actually got to see the manifestation of that a little bit during H1N1 when there was a giant increase in the number of flu cases that sought medical attention. And some work was done by major universities in trying to figure out some alternative ways to see patients with the flu without ever bringing them into the emergency department. Just to digress a second, during SARS, the government of Singapore, being a benign authoritarian regime, they looked at what was happening in their hospitals, and people were canceling elective surgeries and all the things that economically support the infrastructure. And they said, "Stop. We're going to designate one hospital. Sorry, hospital, but you're going to be the SARS hospital." And they found a way to build tents outside and to care for people where they were not getting that coronavirus into the ventilation system of the hospital. So again, the private sector is resourceful, and given the resources to innovate, they will innovate. But what they can't do right now is increase capacity. So they're going to have to change standards of care. I'm told that the National Academy of Sciences Institute of Medicine is working on some guidance for altered standards of care, which would provide some top cover for institutions and healthcare providers that need to do things differently in the case of thousands of people coming into their healthcare institutions.
I want to pick up on this point because I think that I see someone has just asked us a question about the death rate, and there's the difference between the mortality rate, David, and the morbidity rate. Morbidity is when somebody exhibits severe symptoms, but they're not necessarily going to die. Mortality is when they die. And this whole death rate debate has been very interesting. But to underscore what Jeff said, when you think about hospital infrastructure and capacity, if you do use H1N1, which is arguably the nearest term event closest to this, which was in 2009 at the end of the Bush administration and the beginning of Obama, 61 million Americans were infected by that, and it only had a death rate of 0.1%. So it was very analogous to the annual flu. The bigger issue, and the reason why that stressed out the system when we were in office and then Obama had to finish it off, was the morbidity rate. So for our audience that's listening now, there's a lot of debate over, is the fatality rate 3.5? Is it 2.2? Is it 1? Is it 0.1? To be honest, any death at all is horrible and regrettable, but the bigger strain on the system is on a piece of this that no one's debating, which is about 20% of those infected exhibit severe symptoms, morbidity. And that, to Jeff's point...
And those symptoms are you can't breathe.
Like severe symptoms.
So there really is no alternative but to go
to ICU.
Seek healthcare.
Yeah.
And if you look at it right now, in the inventory today, nationwide, even before any of this, there's only 95,000 ICU beds in the country. So let's just use the H1N1 benchmark. If we had 61 million Americans get infected like in 2009, 20% of that, so call it essentially 12 million Americans get severe symptoms, and we've got only 95,000 beds, some of which are already occupied because of the flu season. You're looking at a scenario that I don't care which president this is, I don't care which administration it is, it's going to be, to Jeff's point, a capacity calamity, and there's no way to address that in the short term. And so
but
we're going to have a major potential issue here.
But you're both painting a picture that's pretty grim. I mean, I'm just doing the math in my head. It doesn't seem very likely that that the numbers aren't going to be bigger than what we just discussed. So you're basically saying there is no hospital bed capacity. Put yourself back to when you were the chief medical officer and you were the chief of staff of DHS. Is that you can't stop at that answer. I mean, what happens next? Does the military roll in and set up mobile hospitals?
Mobile hospitals aren't going to touch this problem. We could put every mobile hospital we've got available up, and it wouldn't touch this problem. So what's going to happen is, and you said to set bookends around it. Okay,
right,
so
right.
I'm over at this end. There are enough hospital beds probably to take care of anybody who is sick with coronavirus, but there's everything else, right?
People have to stop being sick of other things.
And so there are going to have to be some choices made as to who gets in the hospital and who does not get in the hospital. If you need a ventilator, you're going to be in the hospital. You'll be somewhere owned by a healthcare system that has people on duty. Hopefully they show up to work and aren't afraid of becoming infected, who are going to take care of people who are on ventilators. They won't fit all in the ICUs. They'll be distributed in other parts of the hospital, which means that other people who elective surgeries, for instance, people who are going to come in for to get their stents and that sort of thing. It's going to be delayed. And again, these are private sector institutions. There are people that don't take orders from the government. The standard of care is determined by a community and the physicians and caregivers in that community. So we are facing a situation in which those sorts that work has got to be done, and it's got to be done at a local level, and the planning is going to be done at the local level with guidance from our policymakers. But ultimately, those decisions and the implementation of those decisions are going to be made very, very, very locally. So if I'm a business owner in a city with one or two major hospitals, I'm asking the question of those two major hospitals and of the local health director, what's the plan? What's the plan? Because that planning has got to be done at the local level as well.
So, and I know we're coming into the final stretch here, but to Jeff's point on this, you can't, there's going to have to be relaxation of standard of care. People are going to have to start triaging who gets to get the bed. We don't have enough respirators. Even, we've had a problem with the national stockpile on face masks and test kits. We'll get ready because the ventilator problem is going to be even worse. So what I think is important for the audience to know too is that if we look at the traditional virus, this may or may not follow the pattern that we've seen in the flu. It is part of the same family. The coronavirus is part of the flu family that has exhibited some, if it gets hot and humid, it could dissipate. So we could get a break before the summer. But to Jeff's point, if we get a break, we shouldn't relax. That should be the moment where we put pedal to the metal and continue to put as much effort as we're putting into finding a vaccine as we are into therapeutics. One way to solve the ventilator problem is if we can get therapeutics that we don't have to put them on a ventilator. What does that mean? Right now, NIH is doing 39 projects, according to Dr. Fauci, who we used to work with, on vaccines, but only 9 on therapeutics. So if the Congress is going to do more in terms of doubling down on targeted aid, one area to look at is can we do a Manhattan Project to push forward therapeutics between now and the time that we have a vaccine? And there are a couple of early signs of a couple of those therapeutics that are looking very promising. But the main thing to note in closing too would be, to Jeff's bookend scenario, what could bad really look like for our audience? In addition to what we talked about of the healthcare system getting overwhelmed, that's likely to happen the most coming into the flu season after the summer, which would be colliding precisely at the peak of our political season with the elections. And so in any crisis, there's always some finger pointing. There's always issues between political parties. This is going to create unfortunately a terrible, toxic type of recipe for an election environment, not to mention the issue around, are you going to continue to have rallies for political events, or are people going to have to stay away from each? How do people vote when they go into a voting machine? Can we keep it safely sanitized so it doesn't suppress voter turnout? And right now, I know DHS is working hard to work with locals to make sure that not only the election system's secure with cyber, that we're also thinking through these second order effects of the crisis. But on that worst case scenario, Jeff, it could get really ugly, both on a political side as well as the capacity side. But what about, to leave the audience with some
Right.
positive note?
Let's do that.
Let's look at some of the, before we
Yeah.
end today's discussion.
So let's do that. So
there could be a better case scenario.
Yeah,
right?
we talked about how contagious this is.
Yep.
And the fact that we have no vaccine and we have no therapeutic, which means that if this thing is going to fizzle out, it's either going to do it because of environmental factors, as Chad mentioned, but I would caveat that by saying this is a coronavirus. There's nothing inherently, there's no characteristic of this virus that suggests that it will diminish with the seasons. It is not a flu virus. We've seen this in other coronaviruses, and there are others that we haven't seen it in. So I wouldn't put my money on that. In order to stop the spread of this epidemic, 2/3, if the R0 is 3, 2/3 of our population has to be immune to it. If we don't do anything else. Well, we don't have a vaccine, so that's probably not going to happen. There will be some immunity that occurs in people who are exposed, develop antibodies and never get sick, or those who have been sick and develop antibodies. But it's not going to be 2/3 of the population. So what we are left with is population behavior. It is a set of things, and I'm not going to repeat them because we've heard them all. It's adhering strictly to that. It's washing your hands after you cough. It's not going out in public if you have a fever or you think you're sick. It is not getting on an airplane if you don't know where that cough is coming from. It might be the flu, it might be nothing. But we are left with developing a population of socially responsible people who can get that transmission rate down to less than me infecting you and you. If I just infect you, this thing will fizzle out. So this really is about public health countermeasures.
Well, that's great. I think we should end on those good words. And I want to thank everybody for joining us on behalf of Capstone and the Chertoff Group, and Dr. Jeff Runge and Chad Sweet and myself, David Barrosse. Thanks for joining us.
Thank you.
Thank you.